60 people in this room. Imagine you are all patients hospitalized at Penn. Some of you came in with heart failure, some have pneumonia, and generally you're all very sick. If you have a blue MEND button in front of you, please raise your hand high. You are in psychiatric distress. Yeah, shouldn't be that many. You are in psychiatric distress. Your medical team has asked a psychiatrist to see you, but this will happen closer to discharge than admission. It's after you're sleep-deprived and anxious. It's after you've been labeled as difficult. It may even be after you've been put in physical restraints. Yet you are the lucky 6%. Now, if you have a purple button, please join the blues in raising your hand. You have not seen a mental health provider, but we now know you should have. Look around. It's nearly half. Almost all of you rate your mental distress as a high priority and want it addressed during your stay. Now, if you have an orange button, please join. This should be everyone. You do not need to see a mental health provider, but you're part of this because your team is busy managing those other complex cases. In the end, everyone's care is affected, and you are all staying in the hospital for longer than necessary. Please lower your arms. That was a workout, I know. My name is Cecilia Livesey. I'm a psychiatrist at Penn, and I'm here today to introduce MEND. MEND stands for Mental Health, Engagement, Navigation, and Delivery. We set out to flip the mental health paradigm, from reactive to proactive engagement, from siloed to integrated care delivery, from sporadic to continuous navigation of complex needs, and we hope to take mental health from costly to sustainable. MEND refuses to accept mental health as a separate stigmatized practice, accessible by the few. It uses 21st century tools and the power of Penn to make psychiatry an integrated part of medicine and our city. But it isn't just our city or our state. Mental health is a national crisis. It is the #1 cause of disability. The majority who suffer go undiagnosed for an average of a decade and die 10 to 25 years younger. The economic toll is estimated at $500 billion a year, and the individual toll is immeasurable. During this event, 180 people will take their own lives. That's more than everyone in this room. We all want to help, and the system is broken, so let's mend it. We started this project knowing 3 things. First, mental health care at HUP is limited. Last year, there were 1,000 psychiatry consults. We've calculated that there should have been at least 10,000. Second, patients with mental health diagnoses were staying here 22% longer. That's an extra 30 hours. Third, patients weren't just being held here longer. They were literally being held here. HUP patients spent more than 500,000 hours in restraints last year. At any point in time, there were 60 individuals across the streets tied to their beds for their own safety and for the safety of those around them. We started on 2 general medicine floors, founders 12 and 14. While rounding with the medical teams, our initial insight was that this was a problem that struck at the heart of our providers. 98% felt that their ability to provide care was compromised by patients with mental health comorbidities. They wanted to help, but the system was broken, so we started to mend it together. Step 1, we moved from reactive to proactive engagement. We wanted to identify patients with mental health needs the instant they hit the floor. So our first innovation was a machine learning algorithm. We knew that chart reviews were too time intensive, and discrete data gave us more noise and signal. So we thought, wouldn't it be incredible if we could bring forward the words that providers already use to describe their patients? Surprisingly, we were able to do just that. We reviewed 300 patient charts, identified those with mental health needs, and trained an algorithm on the raw note text. Today, the algorithm is based on over 1,000 statistically significant buzzwords, some expected, like depressive and suicide, and others unexpected, like victims, noncompliance, and consequences. Step 2, move from siloed to integrated care delivery. Our hypothesis was that by embedding a full-time nurse practitioner, a full-time social worker, and a part-time psychiatrist, we could address patient and provider needs more comprehensively and at less cost. Each morning, the MEND team uses a dashboard prioritized by MEND score and confirmed by rapid chart review to triage patients to the most appropriate provider. While rounding with the medical teams, MEND provides guidance on medication management, interpersonal dynamics, and crisis de-escalation. For patients, MEND delivers evidence-based psychotherapies, motivates patients to engage with treatment, and helps them see and overcome their barriers to care. Now our results. First, we went from identifying 6% of patients to 49%. This may seem high, but it's consistent with the literature, and we're confident that we're capturing nearly everyone in need. And instead of identifying patients on day 5, we're seeing them on day 1. And we're doing this with greater than 85% accuracy. We now see all you purple buttons. Second, in the 4 months before we started our MEND pilot, the psychiatry consult service saw 78 patients. In the 4 months of MEND, we blew past our goal and saw 309 patients, a 300% increase. Leveraging Penn chart capabilities, as well as over 15,000 curator messages exchanged between MEND and medicine providers, we became one team. Everyone was performing at the top of their licensure, and we were fascinated to find that only 1 in 5 cases required our MEND psychiatrist. For patients, the results have been meaningful. We've reduced restraint use by 1/3, and there also have been fewer safety events, hours of one-to-one use, and patients leaving against medical advice. And importantly, there's been a culture change. Providers are more aware of their patients' mental health needs, have more time to focus on the primary medical problem, and call MEND life-changing. Fourth, we needed to know that the solution could be sustainable. We were cautiously optimistic that we had found an economic lever when we saw length of stay decrease by 1 day in the raw data. When we controlled for other floors and other confounding variables, we found a statistically significant reduction in length of stay that was attributable to MEND. And for our most vulnerable patients, our Medicaid patients, we saw an even greater reduction at 1.5 days. Even patients with no mental health needs left the hospital sooner. Providers were more supported, and they were able to deliver timely care to all you orange buttons. We call this our MEND halo effect. With the help of strategic decision support and accounting for the cost of a MEND team, we've estimated we could save the system $2 to $4 million on length of stay alone. And that's just on 2 floors. For Penn, this is a new era of innovation and impact in mental health. For payers, this is truly high-value care. For providers, this creates a culture of wellness. And for patients, this is transformative. But you may have noticed that we skipped number 3, our N. While we saw a small reduction in 30-day readmissions and emergency room visits over the course of our pilot, we knew that helping patients navigate barriers to outpatient care would be our most difficult task. So we asked, how can we set patients up for success? We created a database of over 1,000 mental health resources, searchable by key variables such as zip code, therapy modality, and language, a rough match.com for mental health. But then we asked, what is preventing success? Over half of our MEND population has food, housing, and employment insecurity, and nearly 2/3 reported social isolation, yet they are right here in our neighborhood. So we tried 5 pilots. We called, we texted, we monitored, we visited, we escorted. But none of our interventions worked quite as expected. So finally we asked, are patients able to be successful? When motivation and decision-making are compromised by mental distress, people respond in unexpected ways. They may be less risk-averse. They may not respond to outreach or incentives. They may reinforce harmful behaviors. We have so much more to learn about how to engage with our neurodiverse population, but if we get it right, the impact could be extraordinary. So we've accomplished a lot in phase 1. As you can see, our results are quite positive. But the most exciting part is what's left to come. We used our MEND algorithm to map the areas across Penn with the greatest need. Based on these numbers, there's a strong financial case for adding 6 MEND teams to HUP. This could offer a net savings of up to $20 million per year. And we hope to roll this out across Penn Medicine, in our hospitals, in our practices, and in our community. We also hope to pilot new disruptive solutions to our biggest challenge, navigation. Through partnerships and community engagement, we plan to make Penn the epicenter of sustainable and integrated mental health. And if there's one team that's dedicated, energized, and bold enough to make meaningful change, this is it. Thank you to everyone who made this work possible. We are all helping, and the system is a little less broken, so let's continue to mend it together.